Good evening and welcome. I'm Jen Atkins. I'm the Dean of the School of Civic Life and Leadership here at the University of North Carolina at Chapel Hill. At Skill, we seek to educate citizens who have the courage and the capacity to speak across differences. Our program for public discourse contributes to this mission by offering programming that promotes dialogues on matters of public importance. Tonight, we will hear about America's COVID response. 6 years after the first cases were reported in Wuhan, China. Given that COVID-19 will not be the last global pandemic, I wish it were the case, but probably not. It's important to understand what our leaders did well and what could be improved. Additionally, the American public remains divided about school closures, stay-at-home orders, and other efforts to stop the virus's spread. By highlighting different perspectives on the pandemic, tonight's event will add to our individual and collective understanding of this still fresh history. We're proud to welcome Frances Lee, who will begin the conversation with a brief presentation of her book that's co-authored with Stephen Macedo, In COVID's Wake, How Our Politics Failed Us. Frances is a professor of politics and public affairs at Princeton University. Dr. David Wohl then will present his perspective on both Lee's book and lessons learned from the pandemic. David is a professor of medicine in the Division of Infectious Diseases here at UNC and the Institute of Global Health and Infectious Diseases. In 2020, he was actively involved in UNC's clinical and research response to COVID-19. After the presentations, we will have a moderated conversation followed by questions from you, from the audience. Our moderator, Douglas MacKay, is a professor in UNC's Public Policy Department. During the pandemic, he served on UNC Hospital's Ethics Committee. I want to remind the audience that the views expressed by the panelists do not necessarily reflect those of the university or sponsoring programs. And now I'm pleased to turn the program over to Frances. Thanks.
Could you please put my slides up? Thank you. So thank you very much, Dean Atkins. I'm delighted to be able to be here to have this discussion. I think that that as we reflect back on this period, that there's a lot that we haven't confronted and have not discussed as a community. So this is a wonderful opportunity. My book with Steve Macedo is a story of elite failure. We focus on the performance of the major truth-seeking institutions of liberal democracy, namely science agencies, journalism, and universities. All of these institutions have suffered losses of public trust in the wake of the pandemic. And we argue that this loss of trust is not entirely unreasonable or unwarranted. We are, of course, sensitive to the extreme nature of the crisis. If you think back to March and April 2020, the fear of that time was overwhelming. Hospital wards in northern Italy were overwhelmed, and nobody knew just how bad it could get. New York City was also hit hard, as we all remember. We recognize that decisions were made under conditions of fear and uncertainty, and one can only feel empathy for public officials charged with leadership during such a time. It was the greatest global crisis since World War II. By early April 2020, half the world's population, 3.9 billion people, was under some form of lockdown. It was the worst pandemic since the Great Flu of 1918-1919. So, of course, mistakes were made. Nevertheless, we need a comprehensive assessment. Steve and I began by going back and looking at what we knew and thought about pandemic planning before COVID. There are numerous pre-COVID planning documents that speak to these questions. Just months before the pandemic struck, in November 2019, the World Health Organization published a systematic review comprehensively assessing the various measures that were proposed as potential tools for pandemic management. The report emphasizes uncertainty, rating the evidence in favor of all such measures as either low or very low. On page 3 of the report, there's a summary table listing measures that are not recommended under any circumstances for a respiratory pandemic. Among those were contact tracing, quarantine of exposed individuals, entry and exit screening, and border closure. All measures that would be deployed all around the world in March of 2020. The document discusses school closures as potentially helpful, but it also notes that they raise major ethical issues for families and communities. Another planning document put out in September 2019 by the Johns Hopkins Center for Health Security also underscored that it's uncertain whether restrictions would be effective at preventing or limiting transmission in society. It's important to communicate to political leaders, the report reads, the absence of evidence surrounding many non-pharmaceutical interventions and the adverse consequences that may follow them. Given the skepticism, when and how did ideas for widespread use of non-pharmaceutical interventions get so much support? These ideas gained a lot of currency during the presidency of George W. Bush. During his summer vacation in 2005, Bush had read a book about the 1918 pandemic, John Barry's Great Influenza. He gave a major address and tasked his Homeland Security team to work on pandemic preparedness. This group, in turn, was heavily influenced by the work of a set of mathematical modelers in academia and at Sandia National Laboratory. They developed a strategy document, the National Strategy for Pandemic Influenza. They were especially enthusiastic about the potential for school closures in reducing disease transmission. The strongest evidence in favor of social distancing measures rested on an influential study reporting that cities that had imposed non-pharmaceutical interventions during the 1918 pandemic, meaning closure of schools, churches, and theaters, had suffered 50% lower peak death rates. So that's the flatten the curve idea. On the basis of this research, U.S. pandemic planners began to call for non-pharmaceutical interventions in the event of a pandemic. But the containment strategy that Bush's Homeland Security advisors advocated remained controversial at the Centers for Disease Control and at other health agencies. To adjudicate the controversy, the U.S. Department of Health and Human Services issued a grant to the Institute of Medicine that has since been reconstituted as the National Academy of Medicine in order to review the evidence. The Institute of Medicine assembled a distinguished group of public health scholars, epidemiologists, and biostatisticians. And in the report that they produced, they declared themselves unconvinced. They emphasized that mortality in the 1918 pandemic was only weakly associated with the interventions, and that the model does not explain much variation across cities. The report declined to endorse the new pandemic strategy because, quote, it is almost impossible to say that the interventions, either individually or in combination, will be effective. Among the skeptics of the value of non-pharmaceutical interventions was Dr. D.A. Henderson, one of the most famous and decorated epidemiologists in the U.S., who had led a 10-year successful campaign to eradicate smallpox globally. He had also served as dean of the Johns Hopkins School of Public Health for 13 years. He co-authored a paper critiquing the Bush-era pandemic plans and questioning the use of non-pharmaceutical interventions for controlling the spread of disease. The paper raises critical points about pretty much all the ideas in the Bush planning document and concludes with a blanket recommendation against the use of quarantine during a pandemic. As experience shows, there's no basis for recommending quarantine, either of groups or individuals. The problems in implementing such measures are formidable, and secondary effects, such as loss of public trust in government, are likely to be considerable. So much for the pre-COVID planning. When the pandemic broke out, U.S. policy turned on a dime. The first domino to fall was the Wuhan lockdown, imposed on January 22nd, the largest quarantine in human history to that point, covering 60 million people. The initial reactions among experts here in the U.S. to the Wuhan lockdown was skepticism. Dr. Anthony Fauci said this to CNN. He said, that's something I don't think we could possibly do in the United States. I can't imagine shutting down New York or Los Angeles, but the judgment on the part of the Chinese health authorities is that this is something that, in fact, is going to help in containing it. Whether or not it does or does not is really open to question, because historically, when you shut things down, it doesn't have a major effect. The next shoe to drop was on March the 16th, a bombshell report issued from a team at Imperial College London led by Dr. Neil M. Ferguson. Ferguson was a longtime advocate of non-pharmaceutical interventions who had co-authored papers with some of the Bush-era pandemic advisors. Imperial College's report number 9 made headlines everywhere, predicting over 510,000 deaths in the United Kingdom and 2.2 million deaths from COVID in the United States by August of 2020. The model projected, however, that the implementation of non-pharmaceutical interventions would significantly cut that horrific death toll. Now, we all remember the many press conferences during the pandemic with President Trump and Anthony Fauci and Deborah Birx and others. But the key policymakers during the pandemic were the nation's governors. During the crisis, it was the governors who decided on closures and when to lift them. They also supervised the vaccination campaigns in their states. And amid the crisis and uncertainty, they looked to federal officials for guidance. No clear direction emerged until March the 16th, when the president convened a major press conference with health officials. And this is the kickoff of 15 days to slow the spread. At that press conference, the administration issued recommendations that in states with evidence of community transmission, governors should close non-essential businesses and all places where people congregate, including schools. Lockdowns began to cascade across the states afterwards. Nearly all governors issued stay-at-home orders in the aftermath of that March the 16th press conference. At this point, there were only slight differences. Compared to Democratic governors, Republican governors took a few more days to issue their stay-at-home orders. The variation in the lifting of the orders was much greater. Democratic governors kept their orders in place 2.5 times as long as Republican governors. By March the 25th, all public schools in the United States, serving more than 50 million students, were closed. Across the South and the Mountain West, schools reopened in August of 2020, but nearly half of public schools nationally were still closed in March of 2021. The length of school closures strongly correlates with states' partisan lean as gauged by the 2020 presidential vote. The more Democratic the state, the longer the school closures. At the same time as governors implemented stay-at-home orders, they also imposed other orders to enforce social distancing. To track these patterns, researchers at Oxford University compiled a stringency index to measure the restrictiveness of the pandemic response based on the indicators shown here. The index is scaled from 0 to 100, with 100 being the strictest. This figure displays the average stringency index score for each month of the pandemic for states grouped by their vote for president in 2020, from strongly Republican states shown in dark red to strongly Democratic states shown in dark blue. The most important thing to know here is that the states stay well sorted by party in the stringency of their COVID restrictions, with Democratic states always more stringent than Republican states, and party competitive states tend to fall in the middle range. And this is true no matter what is happening, as the pandemic waves would come and go from place to place. Okay, so we can see that there's a big policy divide based on political party. What were the results? Every state carried out a mass vaccination campaign paid for by federal dollars. There was markedly higher acceptance of vaccines in Democratic-leaning states than in Republican-leaning states. This figure displays cumulative COVID mortality per capita for each month of the pandemic in states, again, grouped by partisan lean. If you look on the right-hand side of the figure, you can see that by January 2023, Republican states had suffered mortality rates nearly 30% higher than Democratic states. However, if you examine COVID mortality across the period before vaccines became available, there's no meaningful difference. The difference in COVID outcomes across Republican and Democratic states first emerge and then grow progressively wider over the period after vaccines were available. The analysis, not surprisingly, points to a strong relationship between states' level of vaccine uptake and their COVID mortality rates. The least vaccinated state experienced fully 1.6 times as much COVID mortality as the most vaccinated state. However, the policies that the states pursued before vaccines were available don't correlate with COVID mortality. States that imposed stay-at-home orders more quickly did not fare better. Keeping stay-at-home orders in place longer does not correlate with better outcomes. States imposing more stringent COVID restrictions did not fare better than those with less stringent COVID restrictions. States that kept schools closed longer did not fare better in COVID outcomes than states that reopened them more quickly. What about the cost side of the ledger with respect to these policies? There's not time to go through all the research in all these areas, but I'll hit a few points. The response to the COVID pandemic entailed the most extensive and lengthy disruption to education in history. The National Assessment of Educational Progress showed unprecedented drops in student learning in reading and math, and there has not been any large-scale recovery since. That poor recovery likely results from chronic absenteeism. Rates of chronic absence have doubled relative to before the pandemic. Learning losses were greater in high poverty districts for Black and Hispanic students and for students who were struggling academically before the pandemic. The COVID pandemic triggered the largest ever crisis response in United States history. Congress authorized more than $5 trillion in new spending, most of which was allocated to keeping businesses and workers afloat through the closures. Gauged by new spending relative to gross domestic product, 2020 pandemic aid was bigger than the 2009 stimulus package and the whole New Deal combined. 2021 pandemic aid was roughly the same size as the New Deal, again, as the share of GDP. All of these expenditures were added to the national debt. As you can see here, the pandemic response caused an unprecedented rise in the debt to GDP ratio, and this higher debt burden will make responding to the next crisis or recession more difficult. Pandemic policy also had effects on population health in addition to the effects of the pandemic alone. There were lengthy delays imposed on non-essential or elective care, followed by significant backlogs once that care resumed. Cancer screening declined drastically. Excess deaths during the pandemic were surprisingly high, even in demographics little affected by COVID. There were surges in deaths due to heart disease, diabetes, overdose, and homicide. Minority populations were especially adversely affected. More than a third of excess deaths among Black Americans are not explained by COVID. Effects on mental health are also well documented. Increases in anxiety, depression, and eating disorders, particularly among children and adolescents. There was also a sharp increase in deaths due to substance abuse and overdose during the pandemic. So what have we learned? We just simply haven't learned very much in scientific terms, or that's the assessment of the Scottish government's independent but government-authorized COVID inquiry, published in July 2023. With respect to non-pharmaceutical interventions, the report concluded, in 2020, there was scientific evidence to support the use of some of the physical measures adopted against COVID-19, namely frequent hand washing and the use of PPE in hospital settings. For other measures, such as face mask mandates outside of hospital settings, lockdowns, social distancing, test, trace, and isolate measures, there was either insufficient evidence or alternatively no evidence, and the evidence base has not changed materially in the intervening 3 years. The situation is similarly ambiguous on the political front. Democratic and Republican governors all claimed credit for handling the pandemic well. Governors across the U.S. remained highly popular through the pandemic, most of whom had approval ratings above 60%. And then they were largely vindicated by their voters. In addition to Governor Newsom and Governor DeSantis, governors associated with every position on pandemic policy resoundingly won re-election in 2022. There's also been no convergence of public opinion about what worked or not. Instead, public opinion about pandemic policy grew progressively more party polarized across the pandemic. Democrats continue to view public health officials positively, while Republican assessments cratered. And it's still in that unsettled state that we find ourselves today, and we'll take this opportunity to have a conversation about this history.
Great. Well, I'll start out by thanking the school, the organizers, for allowing me this opportunity to be part of this discussion, and certainly to Doug for moderating and Francis for coming down all this way. I'm pretty sure there's two reasons that I was asked to be here tonight. One is, and I'm pretty sure this is the case, everyone they asked before me said no. And second is to offer a clinical perspective of the response that we had to COVID-19. And through that lens, look at what happened maybe a little bit differently from what we heard, which I understand is really important, and I think the book is really important. But I think in doing that, looking back is incredibly important. And that helps us always think about how to move forward. And so I welcome the opportunity to look back this way and be critical. We do this in medicine all the time. And as a clinician, many people in this room are clinicians who responded, like me and others, early and throughout the pandemic, and continue to respond because people still come in with severe COVID-19 and require intensive care. And we're very familiar with doing things like morbidity and mortality reports, right, where we look at what went wrong when outcomes don't turn out the way we want. And we do so in a blameless environment where we look critically at what went right and what went wrong to help us understand where to move forward. And I think that's what we're trying to do here today. But I think the difference between what we do with the morbidity and mortality report and what we're doing with COVID-19 is COVID-19 affected all of us. It was extremely traumatic, and we all suffered, but for different levels, right? And so I think that makes it hard, because when you look back at something that was traumatic, it's very natural to filter and misremember or not remember the way things were. And so for me, I think revisiting this, taking on this challenge and getting to meet Frances and read her and Steve's thoughts, it helped me understand a little bit about some of the non-remembering. And so part of what I'm going to do over the next 9 minutes is try to lay out, I think, a little bit of the context with which we were making decisions, the pressures that we were under, the forces that were influencing things. Because retrospectively, we could look at stuff, but in the moment, things were very different. And we know that we were under tremendous, tremendous difficulties. And it wasn't only in the beginning. You've seen these graphs before. This is mortality, weekly mortality in the United States. It wasn't just in the beginning, right? We were not just overwhelmed, we were very overwhelmed, and we switched back and forth between being overwhelmed and overwhelmed. And so I think, again, in the clinical sense, we really felt this very acutely, and that definitely influenced what we were doing. The other thing, and someone in the audience said this, and it was really important for me to understand, is we didn't understand the rules of the virus. Right? This was novel, meaning we didn't understand it, and our immune systems didn't understand it. And we knew it was rapidly spreading, and we also knew it was lethal. So that's pretty scary. So context one is that this was a scary period for us where we were overwhelmed and frightened. The other thing I think that it's really important, and I put here October 16th for a reason, because I think we'll come back to this special date in 2020. This is when the Great Barrington Declaration got announced, and this is a time period where there were 5,000 average weekly deaths that became almost 25,000 the week or two after that. So let's move to the next slide, please. Or do I have a clicker? Perfect. The other thing that we started to understand is that drips and drabs, information was coming out. So this is a data-free zone, novel virus, rapidly spreading, lethal, and we started to understand that young people could die. One of the first people who blew the whistle on what was going on with COVID-19 in China, Li Wenliang, was 34 when he died in February of 2020, famously. That told us that young people, while most of the people who were preyed upon by COVID-19 were older, young people can also die and lose the COVID lottery. That added more of the tension. The other thing is that we didn't realize that people could become reinfected until almost the fall of 2020. Just as we were contemplating and thinking about things like reopening schools, we realized that our concept of herd immunity had to change dramatically. This had major implications for that and for thinking about vaccination if it wasn't going to be sterilizing protection. Frances rightly points to what we knew beforehand and what we didn't know. And I think that's incredibly important. I could tell you at the time that we were talking about this, the things that me and others were debating at this period of time, to give you that context, was whether or not we should flip people over on their bellies to squeeze more oxygen into their lungs when they were on a ventilator. We didn't have a randomized clinical trial telling us proning was going to work, but mechanistically, it made a lot of sense, right? We repurposed antivirals. I'm not talking about hydroxychloroquine or ivermectin. I'm talking about drugs that actually treat viruses to try to treat this virus. Before we had randomized clinical trials, because there was mechanistic plausibility that some of these antivirals might work against this virus. And the other thing is we didn't really debate about whether or not our masks, our goggles, our face shields, or our PPE, once we got PPE, would work, right? We had faith in them. We didn't have great randomized clinical trials that would tell us in a pandemic of a novel, rapidly spreading, fatal virus that our protection would work, but we used it. And I would say without the randomized clinical trial, with mechanistic plausibility, it probably worked. It's anecdata. I can't show you great studies, but I believe that that worked and kept healthcare workers protected. So we had context number 2 that I want to point to, which is the tools that were known and available. And as Francis said, the most proximal guidance expert panel that had met beforehand, met in 2019. So they had looked at a lot of the data that we talked about from earlier, the modeling studies, the controversy. And this is where they came down. And they said there's NPIs that are really well considered and well known. Let's look at the data, let's grade those data, okay? And then issue recommendations. That was the goal of this document. And as Francis said, there's a table and it's not buried in the back, it's not an appendix, it's table 1. And they list all the NPIs, a suite of NPIs that they were accessing. And yes, low data. It's very hard to do clinical trials on these, especially in combination, which is how we apply them. And this table says very clearly that in extraordinary circumstances, which I would say COVID-19 as a worldwide pandemic qualified as, what do they say? Use all the above. No kidding around. Okay, so I think it's very clear that even with low evidence, no randomized clinical trials that can support one or these others, the Swiss cheese method of trying to line up the slices and make sure the holes don't overlap is worth trying in these extraordinary circumstances. So rather than saying we threw away the playbook, we followed the playbook and did the best we can under extraordinary circumstances. And I won't go into the length of this, but I think the document is pretty concise. It's not a very big document, but they do talk about the balancing of the negatives and positives, the costs of some of these. And Francis mentioned that too, and I think that's really key. This was a well thought out document. And it did understand, and even presciently understand, that there could be consequences of this that we will have to grapple with. And I won't get into it, but they talk about specific interventions that have been controversial that are very, very clearly recommended in these circumstances. So within this context too, I think we have to understand that the mindset at the time, especially from the experts that were assembled, really reflected the basic tenets of infectious disease and infection control, which is avoid the pathogen, flee, right? That's what we do. That's what the elites in France would do in Europe in the plague, flee to the countryside. Why? Because it works. Hermits don't get infected. So taking this principle and saying, how do we distance ourselves, like the NPI guidance from the WHO said, keep people away from the pathogen, from the deadly pathogen. So it made sense. I think, again, contextually, it's very interesting to see that NPIs worked pretty well for other viruses at the same time. Not just one, not just flu, okay, but also we're talking about other coronaviruses. Now, they're different. They're transmitted differently. Again, it could be different for SARS-CoV-2 than it could be for these, but it is an indication that NPIs work. And I think we're conflating sometimes in this discussion. I'd be interested during this discussion that we'll have after this and the question and answer. Are we conflating do NPIs work with are NPIs worth it? Because they're two different questions. I would say it's pretty clear NPIs work. And we could talk about whether or not that's true. But I even think in reading the book, I became more convinced NPIs work. We saw this incredibly important graphic that Frances showed and is highlighted in her book. And it's really interesting to think about because when I look at this, I was pretty surprised too by what she showed. But I think, again, this is really tough science to do. There's a lot of confounding. You would never design a clinical trial like this or a clinical study like this because there's too much difference between. This is not everything that explains everything, right? There's other analyses that maybe we'll go into later that show something, if you parse it out a little bit differently, that can explain some of these things. So there's artifacts in here. A big artifact, of course, is blue states. The big populous blue states on the East Coast got hit harder and faster, starting at 0 is not correct, right? We know that. There were deaths way before, we started to see the lines go up in the blue. So there was a lead start. Massachusetts, New York, New Jersey, they got hit harder and earlier. Not so much Ohio, not so much some of the other states, but big populous blue states got hit harder. So when we look at this, I think it's really important to focus on that time period before the vaccines became available. And in the shaded area, I'm looking at that time period where pretty much everyone was kumbaya. Everyone was like, okay, we're in this, we're gonna do this. And we saw that with the severity, with the index of stringency. People were doing basically most the same thing across the states. And when you look at the blue states, I hate to say the word, but it looks like the curve is getting flat, right? Something is stopping what was starting to happen. Again, this is like you have to squint a little bit. But when you look at the red states, maybe the same thing was happening, but once they started rolling back, a month into the pandemic, red states started rolling back some of the mitigation strategies. What do you see? You see an acute increase in red state, in the red lines going up. That's suggestive to me that there is something going on. So even here we see something. Where it ended up, I think it probably would have been worse for blue states than it was. And again, I don't want to get into this, I'm going to skip this from the amount of time, but we saw that New Jersey, of course, got hit earlier than Idaho. Maybe, like we said, Ohio a little bit different. We could look at this other ways by regions that track a little bit with GOP versus Dem. There's a bunch of different ways to parse this. Sweden came up, and I think Sweden's another good example that convinced me NPIs work. And this kind of makes sense too, because even when you look at the Great Barrington Declaration, so for those of you who are not familiar with it, the idea being, look, this is October, the new wave is going to come, but we're not really sure it's going to come. What's going to happen? Maybe we should let people get exposed to the virus. So let's stop doing these NPIs that are harmful and costly. Well, if they're harmful and costly and we want to stop them so that more people can get exposed, ergo, they're preventing people from getting infected. Thus, they're working. So even implicitly, I think in the Great Barrington Declaration, we see that there is this acknowledgement they work. Then it comes up to, are they worth it? In Sweden, too, I think we get great data from this because there's this period in time early where the difference between Sweden and the other countries, Nordic countries surrounding it, is the stringency of their NPIs. Sweden took a route that said, we're going to do NPIs, but we're going to do NPIs light. We're not going to do full bore, full fat NPIs, right? We're going to really try to balance this, paying attention to some of the considerations that Francis talked about. And when you look what happened during the first part of that time, where the difference, the condition of interest that's different here between it and its neighbors is how much they're really adhering to these NPIs, you can see they suffered from tremendous excess mortality, multiple fold of what you see in Finland, Denmark, Norway. Now we'll talk about what happens later, and I think that's going to be key because there's some explanations for that too that we should discuss. Maybe in the end it was a wash, but in the beginning it wasn't a wash. Again, suggesting NPIs worked. So again, why is this important? Because maybe Sweden did okay, but maybe Sweden could have done better. Because you know what we knew, some of us in this audience, in August of 2020, was that vaccines were coming. We were part of Operation Warp Speed. We knew what was happening. We saw the first publications from Pfizer and Moderna that showed that these vaccines were working. It wasn't that long. In fact, they probably, just like the NPIs, probably should have been started before March 16th. And maybe we would have saved more lives in New York and New Jersey and Massachusetts. They should have been available sooner because the rollout was too slow. But people don't realize that at that period of time that Sweden decided to go light, right around the corner was the vaccines. And at the time that the vaccines became available, 90% or more of the country had not yet been infected with COVID-19. So you're allowing during this period of time with vaccines coming down the pike, more people to be exposed to the virus, including, of course, in Sweden, older people who died. My last context, and we'll end on this, and it's a little bit dangerous bringing up politics when I'm on a panel with a political scientist, so I'm maybe poking the bear a little bit here. But for me, the other big context has to do with politics. As Francis said, we both came up with this independent. This is, the greatest national security threat to the U.S. since World War II. And I think the experts, the elites that we're talking about so much, these people who came along and told us what to do, they were handpicked by our elected leadership. Tony Fauci, Francis Collins, Deborah Birx, they did not launch a military coup in Washington. They didn't storm the Capitol, right? These were people who were selected and asked to advise people who make decisions. And while a lot of those decisions did end up going to the governors, those decisions could have been made at an executive level. Clearly, we're seeing today that the executive has fantastic powers to make things happen in states. And that could have been exercised for good at this time, too. So we have experts chosen by elected leaders doing exactly what they're supposed to do, which is provide advice. I would say, in contrast, we had elected leaders, decision makers, at the very highest level of our governments, who I think abdicated their responsibility and shifted the responsibility, maybe to take the blame, maybe so that they wouldn't be responsible. Because if everything works out, you take all the credit. If it doesn't, you have somebody you could blame and vilify. So I think that the contradictory information we saw about when things would be over, what would work and what wouldn't work, I think it fed the partisanship and the polarization. I don't think it's a chicken and egg as much as maybe people think, that there was mistrust based upon the COVID handling. There was already mistrust. People were marching on the state capitol in Michigan, right, in April 2020, not 2021. And I do think this is sad because I think that the NPIs that were effective could have been more effective if they had more support. So in sum, this is what I think, thinking about the context and looking back at COVID-19. The first months and even year, they were scary. There's a lot we didn't know. We didn't know the rules of the virus. And I would say our risk tolerance for death was low, especially among children, right? I think that that has to be key. I think NPIs, A, made a lot of sense. Common sense gets talked a lot about now in politics. And B, were recommended for this exact circumstance. I think COVID-19 paradoxically provides some of the best evidence ever that NPIs work, with the data that I've showed and others. But I think that they could be more effective with the kind of support that we needed. Experts told us what we needed to know. If the panel didn't include sociologists or economists, then whose fault is that? Right? It's the people who made that task force. It's the people who are in charge. It's our leaders, the people who make decisions. And I'd say this is how I'm going to end. I think this, in reading through the book and reading through other articles and reading David Zweig and others, I think the part of the thing that really struck me is probably the most important NPI that we haven't really studied very well is community cohesiveness, is trust in your government, is trying to look out for your fellow countrymen. And when we see countries that did really well, we could talk about whether or not they had contact tracing. We could talk about, how many old people lived in that country. But I think that one common thread through most of the countries that did pretty well, that distinguished them from those that didn't, was how much they cared about each other. And that could have been cultivated. So I think this is the missing NPI. I think the missing NPI is leadership that cultivates and fosters that type of unity and that kind of mission. And I think someone should write a book about that. Thank you.
All right, so thank you both for two excellent presentations. And I think there's some points of agreement, but also some points of disagreement. And I think it's just to say very valuable. I think, Francis, you're sort of approaching this from a more high-level perspective, a more policy perspective, whereas you're thinking of this in part from a clinical perspective. And so it seems like there's at least three questions on which both of you disagree. And I think it might make sense for us just to sort of work through them. So one is, do NPIs work? A second is, are NPIs worth it? I like that distinction that you drew. And then a third is just sort of assessing the performance of our experts. And I hope we'll have time to get to that as well. And so just to give you an opportunity to talk more about the effectiveness of NPIs. Francis, you're very skeptical. I think, David, you're less skeptical. So one thing, just to put on the table is how do we evaluate their effectiveness? And so there's some disagreement, worth talking about through that. But I think one of the other things that I think would be interesting to get your perspective on is also thinking about where are we now thinking about the next pandemic and what sort of makes sense to be in the playbook, right? So I think that, looking at the WHO document, it seems like a lot of these NPIs have low quality evidence. are we in the same place now? Have we learned some important things for the next pandemic? So Frances, maybe I'll go to you first and then David.
So I think that evidence base remains roughly just as unsettled as it was before the pandemic. Part of this is that there were no randomized controlled trials that were conducted, and so that always leaves room for skepticism. The literature is filled with null findings. I mean, the study that Steve and I did doesn't stand out. If you're looking at mortality, there's not a relationship either across the U.S. states or across countries between the stringency of COVID restrictions and overall mortality. Now, that's not to say that NPIs can't reduce transmission. In fact, there are studies that show that they reduce transmission, and yet when we look at the end, there's just not a relationship. It may be that these measures are not sustainable over the timeline of a pandemic. Not everybody can flee, that there's a large share of workers who have to stay on the job to keep society functional everywhere. And the people who are most vulnerable to COVID-19 could never self-isolate as well as others could because they had care needs. And so that may account for some of that slippage between studies that show an effect on transmission and the lack of evidence that it mattered for overall COVID mortality. Looking across Europe, Sweden fared among the very best, if not the best. There are studies that have Sweden faring the best in terms of excess mortality over the pandemic in Europe. Despite wide variation, some countries having 4, stay-at-home orders, sometimes even post-vaccination, additional lockdowns during the Delta wave, even some in the Omicron wave. And yet, so despite the wide variation, there's still not a relationship across countries in Europe between the use of these measures and COVID mortality or excess mortality. So I think, it's very unsettled what they accomplished if we are using that benchmark. I think we do need to come to terms with that, and that we need to re-engage those questions of effectiveness, which were not presented to the public in a straightforward manner during the pandemic. It was treated as this was settled science. When as of November 2019, it was not settled science. It didn't become settled science in March of 2020. It's not settled now. And so we've got to confront that uncertainty. The way Steve and I describe our findings is that they are null findings. In other words, we can't reject the null hypothesis of no effect on mortality. It's not to say that they had no effects, but we can't reject the null hypothesis. So it's not a conclusion that they didn't work. It's a conclusion that we can't be confident that they did.
Yeah, no, there's a lot there. So I appreciate, and I think this is great, because I think there's a lot of commonality among different communities and different thought leaders about this. And so I think that understanding that, there's going to be a point where NPIs, people are not adhering to it. C. Everett Koop said medicines don't work if people don't take it. NPIs don't work if people don't adhere to it. On the converse, a lot of people did NPIs even when their governments didn't tell them to. So we know that that can happen too, and it's very much acknowledged in all the research. There's also something like 76,000 COVID-19 articles published within the last 18 months. So it's very hard to understand what points to the null hypothesis being affirmed and not. You could find studies anyone could pick out, and I've seen a bunch of them. And it is harder to find mortality, but you don't get mortality without infection. And infection, some proportion of people who get infected died, especially during this time. I think it's really important to think about what happened. And I want to get to the communication question and what experts communicated, because I think that's a really important but sort of separate issue, but important issue. I think NPIs probably don't do nothing. I think it makes sense. I mean, that's something we could come up with. And I showed examples where even implicitly there's some understanding that they make sense. So I think with the next, and we joke, when I was talking to epidemiologists and others, and we joked a little bit darkly, if tonight you get an email that at UNC there are 10 college students who are sick with a rash and a fever and 2 are in the ICU, probably not going to have the faculty party tomorrow, and probably school will be closed for a little bit if there's a few more cases next week. So I think we have to think about what we learned and calibrate from what we learned, even in uncertainty, because even beforehand we were talking, when you do a randomized clinical trial, unfortunately, they're not always believed. We've done hydroxychloroquine treatment trials that showed it didn't work, yet people still can get it. And people now are mandated to be able to get ivermectin at a pharmacy tomorrow in North Carolina on demand. So data matters, and I think it is strengthening the argument. And I'm being a little provocative here on purpose, but I think that there are data that show that some of the things we're talking about work to decrease infection, which is already laudable. Even if it doesn't decrease mortality, which I think it does, it's already a good thing to prevent infection. I'm an infectious disease doctor. That's like people pay me to do that. So I think that this makes some sense, but I do think we have to calibrate it. But that takes leadership. That's where leaders come in and say, you know what, I hear your side and I hear your side, and we're gonna make a decision rather than you guys fight it out and I'm gonna stand back.
Maybe that's a good segue to the next question about whether NPIs are worth it. And so, Francis, both in your presentation and in the book, you talk a lot about when we're thinking about implementing various non-pharmaceutical interventions in various communities. We're often thinking about the potential benefits in terms of reducing infection, potentially reducing COVID mortality, but not necessarily thinking carefully enough about the costs. And so one of the things that comes up again, thinking for the future, is just when we're thinking about implementing these things as policies, how do we do so in a rational way? And so one of the things that you criticize is actually what Francis Collins refers to as the public health mindset. Just a quote from Francis Collins, I think from 2023. So he's the former director of the National Institutes of Health. And so he said, "You attach infinite value to stopping the disease and saving a life. You attach a zero value to whether this actually totally disrupts people's lives, ruins the economy, and has many kids kept out of school in the way that they never quite recover from. This is a public health mindset, and I think a lot of us involved in trying to make those recommendations had that mindset." So I think that one of the questions is, if we don't think the public health mindset is the way to evaluate these types of policies going forward, how can we do so in a rational way? And I think also connecting to your point, like, how do we do so at an institutional level where we have the right people at the table? And maybe a question for you, David, is whether you think this idea of the public health mindset, is that sort of a fair characterization of how a lot of people were making decisions? But maybe Francis first, I'll go to you.
So to make decisions rationally, you do have to consider all the expected effects from a policy. These policies had whole of society effects. You might remember that language. We're going to have a whole of government response, a whole of society response. So you have to consider what all the effects are to your best ability to anticipate those. Of course, then there's the problem of apples and oranges. There's effects across so many dimensions of life. And that's where, it becomes a political matter. I very much agreed with David's point about how advisors could only advise, and that politicians, they are elected to make decisions, political decisions. And so, they were trying to hide behind this follow the science slogan to sort of deny that they had the discretion and the power that they had to have in the midst of that crisis. So we needed to acknowledge that that's what we were doing, that we were making decisions about what mattered. I think, in doing that, we ought to have been more open to evidence as it came in. Like, by the end of the summer, it was very clear that the speed with which states had locked down had not made a difference. There was about 3 weeks difference between California and South Carolina, and yet that hadn't mattered. The speed with which they reopened had not made an evident difference. These very blunt, across society measures weren't having clear effects. And we could take that in when schools began to reopen in the fall in the South and in the Mountain West. There was information there. As you referenced, schools reopened in Europe starting in April. And so, we could have been more empirically minded, taking on board information as the crisis unfolded. It wasn't always March of 2020. What you did in March didn't have to govern your approach to the crisis thereafter, but there was a certain rigidity and a failure to learn as the crisis unfolded.
Yeah, again, there's a lot. I think, again, and I tried, and, it's hard in 10 minutes, but the context is that, again, we didn't really know a lot about this virus, and the rate at which we were learning about it wasn't keeping up. And so I think that this was an extremely fraught time, and I think the people, and I give Steve and Francis credit for a paragraph in the book where they said these were well-intentioned people making decisions and giving advice, the experts we're talking about. And I think they tried to do the best they could with understanding that there was a lot we still didn't know. Already we were starting to see that there were some kids who got really, really inflammatory side effects, and also that there were people who got long COVID. So I think it was no secret, thinking back then among the public, that we were flying the plane as we were building it. I don't think that was a mystery. I don't think anyone thought, these guys got it. They got this locked up. They know everything. We knew that this was evolving, this would take time. And I think as we recognize, the mitigation strategies were highly popular over the first few months of the pandemic. It wasn't like the population was kicking and screaming to do this. And in fact, some of the absenteeism we're seeing and saw was parents making their own decisions saying, my school may be open, but we're not going to send our kid. Unfortunately, reading scores and math scores for 9-year-olds suffered everywhere, regardless of lockdown. And it started a little bit lower, of course, in the South than in the other states, but they suffered even so. And I think the pandemic itself did a lot of that. So all summary to say that I think that it's a little messier than as we sometimes remember it. And there was a lot of inventing and creating, and people were trying to be overprotective than underprotective. And I do think Sweden is a really good example. Those people died during that period in Sweden for a reason. It wasn't a different variant. If anything, they were spared a little bit. So there's something that happened there. If there's one example we can show, rather than the red state, blue state, or however, I think that there's examples like that. So again, these people knew that, and they were worried, and they pulled the levers that they could pull to try to protect the population.
I'm a policy professor, so I like to sort of reconstruct the principles at stake here. And so, it sounds like, if we were thinking about reconstructing what's called the public health mindset in a more charitable fashion, we might think it as a more precautionary approach, right? In the sense of we have a lot of uncertainty, we have great risks here, and so we need to be careful about what we're proceeding. And I think one of the other things I notice is just that oftentimes we forget is just the sort of risk of our ERs getting overwhelmed in the early days as well. And then Francis, I think, would you say that, in terms of, considering these things from a really comprehensive perspective, we need to be doing something more like cost-benefit analysis, where we're thinking about not only the benefits in terms of health benefits, but all the costs of other, in terms of educational outcomes, lost income, mental health, other health effects from people not being able to go to the doctor. So I guess one question is just that sort of a good characterization maybe of like how we might reconstruct these principles, and then.
But can I just ask you a question?
Yeah.
I think it's important. I don't think we really disagree. I think it's a matter of degree. I think these things were considered. I don't think there's a bunch of eggheads in the room who are just like, we're public. I don't know. Francis Collins may be also misremembering things a little bit. I think there were a lot of discussions, especially we saw it in the NPI recommendations, that there are costs associated with this. This wasn't done lightly. These were incredibly difficult decisions being made, not by the people who should have made these decisions. We're making some of these decisions in the vacuum of leadership. These were very hard. People knew this would hurt. 1 million people died. We don't have the machine that lets us do the counterfactual to see if Neil Ferguson was right. And I should say in March 28th, 2020, there was a revision of some of this, and it wasn't actually that off for this part of the world. For Asia, it was way off because they did something miraculous, but it wasn't that off. Would we accept 2 million? Like, what are we gonna accept? Like, 1 million people died with what we did, and I do believe it helped. So what are we willing to pay? But I do think these people did really think about it. I don't think it was in a vacuum. And I think that, maybe that could have been more transparent. Sure, everything could be more transparent, but this was very fraught. I think these things were considered. I do. And we talked about it on a local level. I'm talking about like on a health system level, being on these calls, being in these rooms, on the university level. We definitely agonized over these decisions, understanding this is early 2020, that there's ramifications for whichever way we go. But death wasn't very appealing.
I mean, I would say it's certainly essential that you consider the costs. I think that the advisory bodies that were created to advise policymakers were not constituted so as to provide a broad range of perspectives on the decisions. They were basically infectious disease specialists and virology and epidemiology, and then generalist government officials. That's basically what these bodies looked like. And so there's always a risk of tunnel vision when you have only one kind of expertise in the room. And so you're missing out on the broad societal effects. They're not being considered. And so I think when you think about precautionary principle, you have to realize that there was uncertain benefits. They're still uncertain, but the costs were certain and clear. We knew that the costs would be high. So I think that needs, the certainty needs to figure in. And with regard to pharmaceutical interventions, we have to show that they are safe and effective before they are imposed, before they're used. It's not ethical to recommend measures that you don't know are safe and effective. I think with regard to non-pharmaceutical interventions, we need to have a conversation about the ethics around imposing measures where you're not sure whether they will achieve the desired goal. And mortality studies are not providing good evidence that these measures work at the societal level. So that's where we are. We have there's a lot of null findings. We cite and discuss a lot of others in the book, in addition to the graphical presentations across the states. So it's not clear that these measures had the desired effect on reducing deaths. It seems so plausible. I mean, if you hide from a disease, that you won't get it. But what works for an individual may not work at the societal. It may not scale, because of variation in vulnerability, and because a large share of people can't leave the job. And so because of those gaps, that you can't assume a linear relationship between reducing transmission and reducing mortality, and we don't find it in the literature post-pandemic. So I think we have to come to terms with that uncertainty. And as we weigh that, as we look towards future such crises, we have to acknowledge the equivocal state of the evidence with regard to benefits. But the evidence on the cost side, it's clear that there were very severe costs.
So we're basically at time to, I think, open it up to the audience for questions and get people's perspectives and thoughts. So I don't know if we have microphones. We have a microphone available. Great.
Hello. Hey. Well, first of all, thank you for your valuable insights. My question is to both of you. My question is, in light of evidence that NPIs like mask wearing, social distancing, etc., how should policymakers, oh, by the way, these can be cost effective, right? So how should policymakers communicate and implement these measures to ensure public adherence without exacerbating socioeconomic disparities or mental health challenges?
I had trouble hearing the last part of your question. So how should policymakers?
Sorry. How should policymakers communicate and implement these measures to ensure public adherence without exacerbating socioeconomic disparities or mental health challenges?
I mean, I think policymakers do have to be honest with the public about what they know and what they don't know. I mean, I understand that created certain challenges during COVID where there was a tendency to exaggerate certainty. We know what works against COVID-19 was sort of a mantra public health officials used when they would go on the news programs to talk about their recommendations, when in fact they didn't know. that it was not until 2022 that they acknowledged that it was transmitted through airborne pathways, that for a long time the presumption was that it was transmitted via droplets, and so that's the 6-foot distancing. That's how far droplets were thought to potentially spread. So if we spread out more, then we wouldn't be giving this disease to one another. But if it's transmitted through airborne pathways, it's not clear that the 6-foot distance makes much difference. The same thing with cloth masks. It's not clear what benefits were achieved by those measures. We don't see it. We can look not just at variation in policy, but we can look at variation in adherence to policy. Places where people reported to pollsters that they were more compliant with the recommendations, and places where people were less compliant, at least as they described their behavior. That does not correlate with outcomes. The same thing with mobility studies. Places where people stayed home more did not fare better. We can see from their behavior that adherence to stay-at-home orders was better, but nevertheless, there's still negative findings for mortality in those studies. So I think there was a lot of uncertainty, and policymakers failed to acknowledge that in real time. And so it's no wonder that trust has declined in the wake of that. And I think we need to come to terms with what happened, that we were flying the plane as we were building it, and although knowledgeable people might have recognized the ad hoc nature of the crisis response, I don't think the average person was well informed about the experimental nature of policymaking during that time.
So I'll be quick. I think this is a really good question, and I think we could even extrapolate from it. Let's say NPIs, the randomized clinical trials were done, and we believe they work all over the world. Like, this is not ever going to happen because you can't do a clinical trial. Let's say we find masking or distancing or whatever. Your question is, how do we make people feel good about doing it and make sure it's available to everyone because of the disparities we have, the access to healthcare, masks, whatever? I think it's a really good question. I think, again, if we're going to talk about counterfactuals, I think if we had a different president and a different administration at the same time that this happened, we would have had a very different tenor of this conversation. We were working in an environment where already there was anti-everything. There was polarization. It didn't happen a year after COVID. It was there already, and it was fostered and festered. And so you do see a hardening of positions. Look, if there was, God forbid, a fire here right now and somebody said, "Follow me," you would follow them because they take charge, they're leading, and they're decisive. In a crisis, that's often what we want and we need. And a lot of people were very worried that if you give an inch, they take a mile. How much discourse do we need to really have more about whether or not vaccines cause autism? Have we had enough? Have we had too little? Have we listened to the dissenting voices? Or have we not listened to them? When is enough enough to say, you know what? I heard you. We don't believe you. The data. Are they certain enough? They're never certain enough. We can see that happening today on the cusp of rollback of hepatitis B vaccination and other childhood vaccinations that save lives. So let's be very clear. You know what the answer to your question is? Modeling by leadership. I'm the leader of this country. I'm wearing a mask. I'm the leader of this country. I'm rolling up my sleeve right away, and I'm going to be the first one to get this vaccine. We didn't talk about it, and there's, again, you can only have so many pages in a book. But a couple of chapters could be written about the failure of what led to all those excess red state deaths. That was a failure of leadership. And it continues today, where House Republicans didn't get the vaccine, but 90% of Democratic vaccines, 100% got the vaccine. So my answer to you is model your behavior to lead others.
Can you hear me? I have a quick question that I think has got an irony in it. In terms of the slide, well, first I'll make a comment, and that is, when you don't know what you're dealing with, this is the issue, if you don't know the rules, then of course it's very difficult to be dogmatic about what you do. So when a new organism surfaces, you have to make decisions in a blind situation. But the argument that NPIs, so one pandemic organism doesn't teach you anything about the next pandemic organism. So the influenza documents don't really tell us what to do with COVID. And so I have a lot of problem with using the influenza documents as a book, as a Bible for future pandemic organisms. This is displayed really clearly in COVID because we were washing Purell. We've forgotten that you couldn't buy, people raced around the country to buy more Purell. We bought $6 billion of Purell, which had nothing to do with the transmission of SARS-CoV-2. So that's a problem. But the irony is about influenza. David showed a slide where influenza disappeared during the COVID pandemic. So ironically, I think the COVID pandemic proved to us NPIs work beautifully in an influenza pandemic, which we may be facing next year. In other words, if we face a bird flu epidemic, we're gonna have the same conversation again. So I guess I'd ask Dr. Lee, I don't think you dealt with influenza in your book. I'm curious whether you looked at all at influenza, and maybe David could talk more about this. What happened with influenza when we introduced NPIs and actually reduced the influenza vaccine prevalence? That because people couldn't go out, they were less vaccinated, not more vaccinated. So maybe both of you can address that question.
On the question of the pandemic influenza planning, it's true that a lot of the pre-COVID documents anticipated a influenza pandemic. That was seen as more likely. And of course, you know, a lot of the pandemic planning was kicked off by reflections on the 1918 pandemic, and that was an influenza pandemic. But with that said, many of documents also discuss respiratory pandemics. So pandemics spread through respiratory pathways. It's not clear that COVID is different from influenza in that regard. Now, there are other differences. I mean, influenza, there's a lot of population-level immunity to influenza. It's not explosively contagious the way a novel pandemic virus was. And so the kind of measures that we took may have had more effect on the less contagious, given population immunity, influenza virus. A pandemic influenza may not behave similarly to endemic influenza that we confronted during COVID. There are also questions about whether there could have been viral interference, where it's not unusual when a new variant becomes prevalent in a population that other diseases become less prevalent. The incidence of flu also went down in places that did a lot less with regard to non-pharmaceutical intervention. So I wouldn't conclude from this evidence that it was the NPIs and not something else. We don't know there either. But even if it was effective with endemic influenza, that doesn't tell us whether it would be effective with respect to pandemic influenza, which is much more explosively contagious.
Hi, this is a question for David Wohl. I guess it sounds like you feel that what was done was correct, and when I look back at what happened, for me it was pretty clear that what we were being told didn't make any sense, I don't know, midsummer of 2020, and yet we were continued to be told the same things over and over again by experts, quote experts. And it was clear to us that anyone that knows anything about trade-offs could see what the devastation that the lockdowns and the NPIs were causing. And I guess what I would like to ask you is, it seems like you feel that everything was done as well as it could. If we were to have another epidemic like this, would health experts like yourself lock us down again, and based on what? Thank you.
Yeah, no, thank you. I think that's great. So a couple of things. One is, again, with the remembering, I felt like we were locked down for like 3 years. But it was really helpful, embracing to see the data written down in the book and going back and finding out. You know, we're talking about in lots of states, a month after March 16th, people started, coming out and rolling back. So in blue states, it was different than red states, but some of the longest, and I'm not talking about schools because that's a little bit different scenario than what you're talking about. We're talking about 3 months at the extreme, but on average, we're talking 50 days. The other thing is, as opposed to some other countries, where it was much more austere. You can go to the grocery store, no one's going to stop you and give you a ticket. Like, it was hard. It was really hard. But it got better pretty quickly and started to roll back pretty quickly. So I'm not saying we did everything right. I'm talking about what was reasonable under the circumstances and given what we know. What we know now is different than what we knew then, and we both presented data that the people, the decision makers, would have loved to have what the slide sets we just produced back then. So I'm not an apologist for that. Things went wrong. Things went on too long. I had a kid in high school during this time. I know it really well. I know it was really hard for my family not to be able to go out, that businesses were closed. But I do think that there was a reason for this, and I think there were true experts. If you didn't like the experts, well, then we have to think about, well, who chose those experts, and should they have chosen other experts? Don't blame the experts. Say, who's the guy or people that chose those experts? Why aren't we holding that person accountable? I don't want to keep coming back that this is all Donald Trump's. That's not what I'm trying to say. But I'm just trying to make sure that we understand and encompass all of who makes decisions in our country during an unprecedented public health crisis. And I think we're pointing our fingers at some of the right people and not always. We can't look away. We can't look away from the right-wingers who were telling us from the beginning we shouldn't wear a mask without data, okay? They didn't know anything about null hypothesis. So I feel your pain. We all felt the pain. I think it was reasonable to save lives. And we don't have the counterfactual that if we didn't do that, would it be 2 million? Would it be less deaths? I don't think so. Would it be more deaths? Probably. How many more? We'll never know, fortunately.
So,
Francis?
on the expert consensus around what to do, that emerged in March of 2020. There was a lot of expert debate in early March of 2020. You had former CDC Director Tom Frieden saying that we could close schools and achieve no health benefit. You had Dr. Osterholm at the University of Minnesota saying that governors were just following one another off the edge of a cliff. That was language he used, for attribution, with a newspaper reporter. So there was a lot of disagreement.
Right.
That instead we saw this strange herding that began to happen after the stay-at-home measures were introduced, where it became impossible to raise any questions. That it seems quite politicized and manufactured rather than something that was organic in the expert community, there was a lot of internal debate about non-pharmaceutical interventions. The evidence base, you had Dr. D.A. Henderson saying, societies function better through crises like this when they're least disrupted. Very different views on these matters.
That's right, and I think that's really important. That's why I have to admit to a little bit of frustration sometimes when I was reading the early chapters, because there was disagreement. There were public figures who were disagreeing about this very publicly in media that was read not just in back rooms. So I think there was a robust discussion that it went a certain way. It had to go a certain way. And if it went a different way, we might be discussing why didn't we listen to Fauci? So I think, again, I understand what you're saying, but I am also heartened by how much discussion you documented that was going on at this time. And it reminded me that there was robust. Now, was there one person's railroading is someone making a decisive opinion based upon the expertise. Should there be more experts in the room? Should there be dissenters? I don't know how you do that. But I do feel very clear now, understanding what you've documented and going into a little bit more literature and going back to some of the posts and things people were writing back then. There was much more robust discussion than I even remembered at that time. And I'm glad you brought up the examples you brought up. Prominent people who are saying we're not necessarily doing this the right way. That's where you need someone to make a decision.
Right, and what was so striking is how that dried up as of April. You mentioned the Great Barrington Declaration, so that's October. But through the summer, you didn't see this same kind of open discussion. So Tom Frieden no longer speaks out on school closures. People who had taken stances against these measures, they fall silent. They're not publishing in the newspapers. Now, I also think there was adherence to an editorial line in the major media outlets, not platforming experts who were questioning the policy. And of course, you also had pressure on social media companies, even under Trump before before the Biden administration. So you could, questions about masks would get you deplatformed. Questions about whether lockdowns worked, that would get you thrown off of those social media platforms. So already there's sort of a policing of the discourse, beginning shortly after the lockdowns were first initiated. Yeah. And that carried through in a way that I think was very misleading for the public about the state of the evidence.
Yeah, and I agree. And I think this is a really important part of the discussion and a big part of your book. And I agree. I think that there was a mentality that was hardened, we've got to do this. This is for the betterment of the country. We've got the backing of the executive branch because they haven't fired us yet. We're doing this. I do think by summer when states, as you said, the states started to take over a lot of the responsibility. Governors were making the decisions now. I think there was a little bit less pressure because a lot of states were opening up. A lot of states were doing exactly what you said. They were taking the advice of the people who said, you know what, maybe this is not a great idea. And governors were coming out and saying, you know what, we're reopening. Ron DeSantis, as you point out very clearly, said fall 2020, we're opening. So I think that also took some of the steam, I think, out of it. And I also feel like plenty of people were able to get lots of dissenting views, even if 90% of the mainstream media was covering positive party line stuff. Access, even with some of the restrictions you're talking about, it's like whack-a-mole. We all know people definitely were in their echo chambers and getting lots of information, feeding their conceptions. So I don't know that it was all shut down, but I do think that's part of it. People were voting with their feet, right? The mitigation strategies were starting to fall apart, even in blue states.
I'd say the lack of debate in expert communities and university campuses, right, in what we call the mainstream media. I mean, it's very striking, that there's an orthodoxy that prevailed. I mean, this is an unusual conversation that we're having here tonight, and it's 5 years plus afterwards. These did not happen in real time, despite the uncertainties that policymakers were confronting. And I'd say there's something wrong with that.
So, Francis, do you have a theory of just why that occurred? I mean, one thing we've sort of talked a little bit about is just partisan polarization. And do you think that, maybe in the early days, there wasn't partisan polarization around the pandemic and sort of the policies that were being put in place, and then that changed, and then it got polarized, and people felt less comfortable having an open debate about these issues?
So the polarization of the pandemic was an unfolding process. It did not begin as polarized as it ended. That at the outset there were some partisan differences, but they're relatively subtle. Like Republican governors are a little more hesitant to lock down. There were some public opinion differences on the scale of the threat, with Democrats a little more afraid of the consequences of the virus than Republicans. So you could see some differences, but they just grew over time. I think, as we think about the politics of that period, we also need to recognize that it was an election year. And so there was a lot of politicization around the crisis from that vantage point, with many Democrats starting, in March, saying that this had been mishandled by the administration. Of course, that's what the opposition party does. But it becomes a partisan narrative where literally everybody who died of COVID, that was laid at President Trump's feet, even though people were dying all around the world, because it was an election year. And so you got politicization around that. Can we trust our leaders or not? And with the out party, of course, pressing the case that no, you can't. And so it's amazing how partisan the response was. Like, the best predictor of how long schools would stay closed was the partisan lean of the jurisdiction. I showed data that at the state level, but it's also true at the school district level. The counties sort by their partisan lean. Like, literally everything about the response to the crisis became structured by partisanship in such a remarkable way, and that makes the U.S. response quite different from other countries where it never polarized to that degree.
Absolutely. I think that's exactly part of the problem.
All right, so we have one question here, and I think we have someone in front who had a question. No,
Yeah.
Okay, and then one over here.
Thank you for this debate and conversation. I think it's pretty hard to, I'll just first say, I think it's pretty hard to derive the partisanship that we're experiencing in this country right now to any one cause. And I even think that partisanship, sort of figuring out where it started during the pandemic, just around that topic, pretty tough to make that call. My question, though, is different. My question is, I've noticed there's a kind of intractable difference between the two of you. David, you're talking about NPIs that's working, and on an individual level, because you didn't know what the disease was, right? Or the virus was. And I'm just a literature professor, so I'll get the terms wrong. And you're saying, no, they didn't work because we're looking at the mortality rate. And I feel like that if I were a leader and you were both on the team, I'd be I wouldn't know what to do, because the mortality, as you're describing it, Francis, is, it's not working. But you're saying, David, on an individual level, of course it's working, and that seems undeniable that if you're not exposed to the virus, you're not going to get it. So I don't know how you would resolve that, actually. So I wonder if you could both talk about, because I think there clearly is a truth to both of those, right? And I would love to hear you kind of acknowledge, each other's point of view. Like, how do you bring in David's point about the undeniability of, if you don't go out, you're not going to get it, right? And that maybe has a consequence for 1 or 5 people. How do you bring that into your point about mortality generally, and how do you bring her point, David, about mortality generally into your point about the disease?
I mean, I think political judgment is inevitably involved here. Like, it's the science doesn't speak to tell us what to do. I mean, there's even if NPIs worked for reducing mortality, even if we could see it clearly that places that did more had achieved better outcomes than places that did less, if we had that, we'd still have to ask, was it worth it for the other harms that were inflicted? There's also questions of intergenerational justice. Like, the harms were disproportionately inflicted on the young in terms of their educational opportunities, their job opportunities, their life prospects. And the benefits, to the extent that there are benefits, would have accrued to people who were at more risk. So that's also a political judgment that has to be confronted. I think, if I were a policymaker confronted by these conflicting evidence, I would advise people about what we know about transmission. And for those people who are positioned so that they can stay home, can do it. But not to impose measures that we know harm society without being confident, having some degree of confidence that they would work to reduce death. I would hesitate to do that. Instead, I would take a more advisory approach, that is more like what Sweden did. They did do some broad-based NPIs, not to be sure, but they were more sustainable. They did not have lockdowns and reopening and lockdown again. Instead, it was telling people what we know, and then allowing people to adjust their behavior in accord with the information that they were provided. I think that's a safer course of action as a policymaker than to mandate measures that you're not sure will work.
Yeah, I appreciate what you're trying to do, and I think if you turn the clock back and ask the question, should we do back then versus now, I think it's different. I think back then there was an opportunity to do this in a different way. I think the people making the decisions were circling the wagons too, and they were forced to. There was even, as we know, oppositional figures within these groups that were purposely there pushing back and dissenting against this. So that's the modus operandi of the leadership at the time. Put people together who don't agree and let them fight it out. And I don't think that's the way that we make these kind of decisions. And so I think now the well has been poisoned, and I think it'll be very hard to do what you're talking about. The way, obviously, forward is when you have people who trust their government, as many, many countries did. We're sort of an exception, where you have governments that are trusted by the people that they're trying to do the right thing. People take their own initiative on an individual level that gets writ large. And we do see changes in a lot of countries that didn't have to mandate anything, right? People did it on their own. They did it voluntarily. And we have really good examples of that. And I do think that's cultivated, as I mentioned before. So I do think there's a middle way. I think a middle way would have been, we're not circling the wagons. We're not having to act defensively, as I admit I was during a lot of the pandemic, especially during the early days when decisions were being made. Like, why are you doing that? Because we should be doing it totally differently, even though there was no reason. So again, I think that measured response with frequent checking in, is this working or not, and rolling back and not seeing that as a failure, I think that's the way to move forward.
All right, I think we have time for one more
I thought
question.
I would try to see if we could have two people ask very quickly, and then the panel can decide.
Okay, I'll try to be quick. First, thank you both. And I do want to give a shout out to Dr. Wohl for setting up an exemplary testing system here at UNC, a drive-through system that benefited so many in this community and across the state. I guess my concern is that I think there's an oversimplification in talking about mortality rates rather than the spread of the disease, the burden on hospitals, and all the benefits that did come from a rapid response and from the short-term shutdowns that happened in limited ways, in differing ways in different states. So I do want to ask you both slightly different questions related to that. So Dr. Wohl, I'm wondering if you could talk about the benefits of the NPIs more broadly than just in mortality rate. And then for Dr. Lee, I'm wondering whether you considered looking at rates other than mortality, such as tracking the disease. I know in our local schools I was tracking the disease in the Chapel Hill School District and created a dashboard, and we saw a spike in cases on the week that we stopped having masking. And that was even after the Omicron wave. So I'm just curious if you considered other trends other than mortality and whether you included those in your study.
Do you want me to speak first? So we do discuss in the book, even though Steve and I did not do new analyses of transmission, we discussed the literature that shows that non-pharmaceutical interventions had effects on transmission. So that's where the best findings are for NPIs. It's on transmission. It's not, these are not huge effects, but they are measurable. But they don't translate in any clear way into overall mortality benefits. So, and we don't have good data on long COVID, the incidence of long COVID. There's not been an agreed on definition in the literature yet, so we just don't know. So in approaching the question, we felt that if these measures had the kind of effects that that we most wanted to see, we wanted to save lives. That's the terms in which they were justified. If we can't find it there, that has implications for their effectiveness on other dimensions. But you can't assume a one-to-one relationship. But we need a lot more work. We can show that there's a reduction in cases, but for measures that, in the end, everybody winds up getting COVID, or almost everybody. So the question then is whether we've reduced the burden of disease in society or had some other benefits short of mortality. And I'm not aware of research that shows that we had benefits there either. We can see it on cases. We can't see it on deaths. And in between that, there's a difficulty of collecting comparable data across jurisdictions.
Yeah, thanks for your question. And it gives me an opportunity to say that there were so many people, including many in this room, who just did incredible stuff, much bigger and greater than I did, and saved lives, like clearly saved lives. And saving lives is one thing, and also saving people from getting really sick or saving people from getting long COVID. Because some proportion of infections, people who don't die, they get sick. So we can all agree. So if you're reducing infections, you're reducing the number of people who are getting severely ill, and you don't get long COVID unless you get COVID, right? So we know that reducing infections alone, that alone is a good thing, right? So that goes positive. And I think many of the things we do, if they were able to do that and decrease the incredible burden, I didn't mention, you know this, and it's not just one of these, again, war stories. We were put in the position where we were setting up hospital beds in parking lots. Like Samaritan's Purse, which goes to Africa to help people set up Ebola treatment units, was working in North Carolina to set up, so we needed to do something to reverse the burden, to lighten the load, let people we were running out of ventilators. I know the statistic that maybe our hospital census was 90% of what it was, but I could tell you who was in the hospital at that time was intensively ill people. So the quantity of sick people, was very high, the proportion of people. So people didn't come in. Excess mortality actually went down. There's other things. We see bad things that happened during the pandemic. Car accidents went down, right? And the air got cleaner. This is not why we did this, but there are other things that we could look at that happened during the flattening of the curve that worked pretty much like we were intending it to do. And if as a country we think that's important to keep our healthcare workers not burning out, keeping enough ventilators and ECMO machines there for people who need them, then the things we did to answer the gentleman who asked the question, was it worth it? Like, for some of that could have been worth it, even if mortality wasn't as demonstrable as we'd like.
We're out of time, so thank you both for a very rich and engaging discussion.